All right, we're going to be talking about the rush exam, the rapid ultrasound and shock, both practical talk about how to acquire the windows as well as what some of the major pathology looks like. And we're going to be going through a lot of scans here, and it's going to seem like it's a little bit confusing. And it reminds me of this picture here with Oprah Winfrey saying, "You get an ultrasound, you get an ultrasound, you get an ultrasound. Everybody gets an ultrasound." And it reminds me of that because we're doing 3 different regions with the rush exam: the pump, the tank, and the pipes. Now, there's a lot of other protocols out there for resuscitation. The 7-Up protocol, there's something called ACEs, etudes, the FATE exam, FEEL, all these things. But I like the rush exam because it breaks it down pretty simply into the pump, the tank, and the pipes. And you can find this article in this book called Emergency Medicine Clinics in North America. It's kind of hard to track down. If you want the article, just email me and I can tell you how to get it. But basically, it's this using ultrasound in these 3 ways. With the pump, we're going to be looking at 3 views of the heart. With the tank, we're going to be looking, doing an IVC approach as well as an eFAST. And then with the pipes, we're looking at the aorta and the DVT. Now, for all 3 of these areas, the pump, the tank, and the pipes, if you have a problem in one or more of them, that may be causing your patient to have shock. And so you want to optimize that patient shock. You want to pump up their tank and make sure their pipes aren't clogged or ruptured, and you should have a nice outcome in your resuscitation. So I utilize this rush protocol and then portions of it as I'm resuscitating my patient. So we're going to start with the pump. Now, with the pump, there's 3 views we're going to do. There is a parasternal long axis for E-point septal separation, and there's RV strain using the apical 4 chamber, and then we're going to be looking for tamponade, and you could do that in the subxiphoid region. And I also talk about how to confirm it using the apical 4 chamber and using pulse wave Doppler, but we're not going to get into that. It's a little bit off topic here for the rush protocol, but certainly we're going to be talking about the subxiphoid view. And with the heart, the 3 views, you've got the parasternal long indicator towards the patient's left hip. Apical 4 and subxiphoid, we leave those indicators to the patient's right like we do everything else in point-of-care ultrasound. And when we're doing the rush protocol, because we're moving all over the body, we leave the indicator in the radiology component side of the monitor. Now, you can see here, for the parasternal long, we're using that low-frequency phased array transducer with the indicator down towards the patient's left hip, and we're getting a longitudinal view of the heart. We're stretching the heart out across the screen along its long axis, where you can see the left ventricle, the left atrium, and the aorta. Right up here, but not drawn in, is the right ventricle. So it's really a 3-chambered view, the parasternal long axis: right ventricle, and left atrium. And you can see the mitral valve, particularly the anterior or septal leaflet of the mitral valve. During diastole, you can see the E and the A wave, the early wave of diastole and the atrial kick. That's why it does that little bump, 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 bump during diastole. All right, here we see the parasternal long axis. We see the left atrium. And during diastole, the blood flows into the left ventricle, goes through that mitral valve, and that mitral valve comes up and smacks in that septum right there. You can see it. Bam, bam, bam. Who's your mitral valve? Who's your mitral valve? You see that, how it smacks that septum? That's normal. That's what you want to see. That's good. And so if it's not coming up and smacking that septum, then we're having a problem with our contractility. And so what we do is we look at that area very closely. Like in this patient right here, we can see that mitral valve is definitely not coming up and smacking that septum like that last patient. And so this patient's got poor left ventricular function, and we call this a positive EPSS. What do I mean by that? Well, E-point septal separation. So basically, at the where that mitral valve is supposed to come up and smack that septum, it's not doing that. And we can actually measure the distance that mitral valve tip comes to the septum. And if it's more than 7 millimeters, then you have a positive EPSS. I mean, we can sort of see the centimeters over here. I said 7 millimeters, so it's got to be like, less than a centimeter right up here against that septum, and it's clearly not. So this patient they got EPSS in the 30s or something. I don't know, something crazy, but it's definitely positive. So again, here's that normal patient with that M-mode spike. I'm going to put it right here through that interventricular septum across that mitral valve, and then I'm going to measure the distance that tip comes to the septal wall. It should be less than 7 millimeters. And when we do that, we just take our M-mode spike here, and we can see this machine does live B mode and M mode at the same time, and we can see the EA, 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 EA. The E is the early phase of diastole, the A is the atrial kick. And this is the septum kind of wiggling along over here, and if you just took some calipers and you measured this distance right here, that's going to be your EPSS, and that should be less than 7 millimeters. Now you can sort of eyeball it up here, and you can see how that septum is getting pretty. That mitral valve comes up pretty close. The septum even touches on some of those views. So, you can sometimes just eyeball this, but if you want it to be very precise, you can then drop your calipers less than 7 millimeters. And there's a formula. It's pretty simple. You take the ejection fraction. It's the estimation of ejection fraction. 75.5 minus this quotient here, 2.5 times EPSS in millimeters. And so, in this case, the EPSS was what? 18 millimeters. And so you can see it too. You can see how this is just EA. EA. Pretty weak. It doesn't get up near that septum very well. This distance here, 18 millimeters, when we take 2.5 times by 18 and then you subtract that from 75.5, guess what? You get 30% ejection fraction. That's bad. Like a normal ejection fraction is, somewhere in the 60s. 30% is definitely pretty bad there. So you want to you can use this as an estimation. Now, it's not perfect, but definitely this is a way you can help guide your resuscitation. Now, this is somebody who's got an ejection fraction of exactly 0. This is, unfortunately for this patient here, here's our left atrium, left ventricle. There's that mitral valve leaflet. Here's that septum. It's not moving at all because this is called cardiac standstill. And you may use this as a way to terminate your resuscitative efforts. And if you don't believe me, take it from the EMC.
Patient with shock and dyspnea, the echo is essential. Gotta know the EF with CHF on the differential. Here's how to use the echo, checking for gross systolic function. If you've done this enough times, you can just make an assumption. But if you get stressed, not satisfied, and just guess, the best test on the fly to quantify the EF is to identify what's called the EPSS. You find the septum in the mitral valve anterior leaflet, and during diastole, it's the distance between them, cause the amount the valve opens based on the flow that's going in. So you can know what preload is, and this is used as a proxy to approximate what's probably going out to the body. Cause just like a lot of people going through a door, a lot of blood to a valve is gonna open it more. So the more the valve opens, closer it gets to the septum. So the normal EPSS is less than 7 millimeters. If it's more systolic function depression, use your gestalt impression. A M mode, you wanna measure it. Less than a minute, test it. Bedside of that, that's an ejection fraction wrapped on it 1 minute flat.
All right, let's give it up for the EMC. Amazing work he does. He's a resident. He was a resident at Highland Hospital. Now he works out on the East Coast. Now moving in along in the pump, we're going to change gears now. We went from that EPSS and that parasternal long view. We're still in the pump, right? Well, another cause of someone to have low blood pressure is not just a failing heart, but it's also a blood clot in the lung. And the way we're going to decide that very acutely with ultrasound is look at the right ventricle compared to the left ventricle using the apical four-chamber view. We have the indicator aimed at the patient's right, and this is what we see here. Now, normally, that right ventricle should be 2/3 the size of the much larger left ventricle. You can see it here. Here's the left ventricle. This is a big left ventricle here. Here's your smaller right ventricle over here. The other thing it denotes the right ventricle is this little moderator band right here that conducts the electricity. You can tell that that's only found on the right side of the heart. That's how I confirm that looking at the right side of the heart there. Now, to get that apical four-chamber view, it's the hardest window to get of the heart. It's maybe one of the hardest windows to get anywhere in the body of all point-of-care ultrasound. I kind of put this up there sometimes with appendicitis. Like it requires a lot of patience to get this view and kind of patient repositioning and stuff. So I tell the patient to roll into a car model position, and it's amazing. You could say this in any language, and patients immediately just they think about it for a second, then boom, they roll over to the left side. And then you can put your fingers where that PMI is, that point of maximal impulse, that dime-sized area on the chest wall where the apex of the heart comes to the chest wall. And then you just plop your probe right on the PMI, and then boom, you're going to get this nice apical four-chamber view where you can see how that left ventricle spreads out down the screen into the left atrium, and there's that right ventricle coming out of that right ventricle coming down the right atrium here, and a nice 2/3 size of the RV compared to the LV. Now, this is somebody over here who's got a massive pulmonary embolism, and you could tell this RV is as big, or even bigger actually, than the LV. And the LV starts to get smaller. Why is that? Well, because the blood is getting stuck. It can't get its way through the heart and back around. I mean, it can't get its way through the lungs and then back around the left side of the heart again. So the LV starts getting emptier and emptier as the patient's getting more and more into shock. And you can see how this process is starting to take its toll on the patient. Again, this is the moderator band up here that confirms that that's the right ventricle. And if I saw this patient in my emergency department and they were going to cardiac arrest or their blood pressure is super low, almost unobtainable, I would give them a clot-busting drug such as tissue plasminogen activator. So it is indicated in the setting of shock for pulmonary embolism. Now, switch gears again with the pump. We talked about the EPSS using the parasternal long. We talked about comparing the right and left sides of the heart with the apical fourth chamber. The other thing that causes shock is pericardial tamponade, and we're going to be using the subxiphoid view primarily to pick up that diagnosis. The trick with the subxiphoid view is to get right underneath that liver and aim the probe towards the patient's chin, not to the left, because you got to use the liver as the window to see the heart, right? So if the eyes are the window to the soul, the liver is the window to the heart in the subxiphoid view. So I start actually with my indicator of the patient's right, I'm looking up at that beautiful organ, the liver, so easy to see. I just kind of like shimmy the probe right up into this xiphoid, subxiphoid, xiphy-xiphoid area here, and I have the patient take a deep breath, if they're not already huffing and puffing, and I can usually see the heart pretty well there. And this is what it looks like here. This is a pericardial effusion. We can see the liver sort of at the top of the screen. The pericardium is coming along here. Here's some fluid here. Here's the right ventricle, the left ventricle. This is the posterior pericardium. I don't see any fluid back here. Here's the left atrium and the left ventricle. That definitely you could see that fluid there. Now, one of the questions you have is, hey, is this pericardial tamponade or not? Tamponade is when you get so much pressure inside the pericardium that that during diastole, when the right ventricle is supposed to fill, it actually collapses. And we call that paradoxical right ventricular collapse during diastole. And it's a little bit tricky to tell just by watching the heart beat really quick because they're usually very tachycardic in this setting. Kind of like that PE patient was super tachycardic. These tamponade patients are tachycardic, trying to compensate for the fact that the cardiac output's dropping so much. And so it's a little tricky to tell, but I like to think about the trampoline effect, like this little person jumping up and down a trampoline. If you see that along that free wall of the right ventricle, man, think tamponade. Or if you see what's known as the John Travolta move, and I'm going to show you what that looks like right here. So this patient has pericardial tamponade. There's the liver up here. It's a subxiphoid view. This is the pericardium coming along here, okay? And you can see all this fluid here. In fact, there's clot here. This was like mediastinal gunshot wound. And so it went from the right chest across and exited the left chest. Bad wound to get, obviously. And you can see some clot here. And this LV down here, here's your left ventricle. It's empty. In fact, the papillary muscles are kissing. We call that kissing paps. And that's an empty LV. This patient is about to code. And we can see the right atrium and the right ventricle kind of dancing back and forth. You see the free wall dancing back and forth. If you see that, particularly in the setting of an empty LV, this is an indication to do a procedure to get that fluid or that blood out of there. And two procedures you can do. You can do a pericardiocentesis, or you can do a thoracotomy. Cut the chest open, cut open the pericardium, and just drain out the blood that way. Depends on the situation, which I won't get too into here. But the thing that reminds me of this is John Travolta. Check this out. Look at John Travolta. It's like when he made this movie, Saturday Night Fever, back in the 70s. It was like he was thinking about tamponade doing that move right there. I mean, it's really kind of this thing right here, isn't it? So if you see that, start to elevate the level of the panic, so to speak. Now, this patient was in my emergency department a few years ago, and he came in. He's a Vietnamese-speaking guy. He came in with what we thought was epigastric pain. He was pointing to his subxiphoid area. So the medical student in this fourth year of medical school went and looked at the gallbladder, thinking, "Oh, this is like, abdominal pain," and which is pronounced đau bụng in Vietnamese. We see that a lot. Đau bụng means abdominal pain. And so we're like, oh, we got some đau bụng going on. We got to check out. Maybe the patient's got gallstones. But we were wrong, actually. The patient was short of breath, but he was actually pointing at his heart. Because if you look down here at his heart, here's his pericardium over here. And there's something going on over here. The heart's beating inside a sac of fluid. The medical student notices this, switches probes to the cardiac probe, and swiftly makes a diagnosis of pericardial tamponade, which is great because the patient started to become hypotensive, and we immediately did a pericardiocentesis and saved this gentleman's life before the translator even got to the bedside. Another case of tamponade, and again, you can see that sort of John Travolta move going back and forth through that, or almost like a trampoline. It's this little tiny person jumping up and down on the free wall of that right ventricle. That should alert you to pericardial tamponade. And the LV looks pretty empty down here in some of the windows that we can see it in. So this is definitely a really intense emergency when you see some tamponade, and an ultrasound is a very, very sensitive and specific way to make the diagnosis. So back to the rush protocol. Again, I said it was simple, right? It's pump, tank, pipes. All right, we talked about the pump. That's the most complicated one because we got to get 3 views of the heart when we're doing our pump protocol. Now we're moving on to the tank. It's a lot easier to do the tank because we just got 2 things, the IVC and the eFAST. So let's talk about that. So for the IVC, we're going to be using that hopefully large curvilinear transducer. We could use a small cardiac probe too, but I like using this large footprint transducer. We're going to be looking at the IVC with that. And then we're also going to be doing an eFAST, an extended fast exam, where we look in the body for evidence of fluid and also for a collapsed lung. And that's what an eFAST is. So the IVC, we're talking about the tank here, okay? Now when you resuscitate somebody, you want to make sure that you're maximizing their stroke volume. You're trying to find out who's going to be the fluid responders. And when you see a flattened out IVC, especially when someone takes a deep breath and that IVC flattens out, you just did a provocative move to them, and now you're able to figure out who is going to really respond with a maximal stroke volume with a small change in preload. And that's what we're trying to identify on this Frank Starling curve. So there's other ways to think about how full the tank is. I mean, you can just sort of eyeball the heart and maybe measure the cardiac output without really doing a provocative move to the patient. But if the patient is on a ventilator and we're watching their aortic blood flow change with respiratory variation, not going to go into this in the rush protocol so much because I'm really talking about the non-intubated patient right now. And for a patient that can follow commands, have them take a deep breath who's spontaneously breathing, and if you see vena cava collapsibility, boom, you know this patient's going to require some IV fluid resuscitation to get him back on that Starling curve. You can also do some passive leg raising, which requires you to kind of move the patient in the bed and Trendelenburg and lift the legs in the air and all this stuff, but I'm going to skip that for now and just really focus on the IVC collapsibility. So when you take a deep breath, your IVC collapses down. You can do it right now and try it on yourself, and especially if you had a few cups of coffee or another diuretic like alcohol, you will see that your IVC will collapse down during inspiration to greater than 50% of its pre-inspiratory diameter. And that's kind of how we decide when somebody has low intravascular volume. They take a deep breath, this IVC is dumping into the right atrium of the heart. You're going to take that nice curvilinear transducer here. You're going to move it, it's called parasagittal right. Okay, parasagittal right, meaning you're in a sagittal plane, but you're kind of off to the patient's right, where you would expect the IVC to be. Now, I kind of push down. I push down really hard. I'm not going to lie. Sometimes I use 2 hands, and I drag the probe right up underneath that rib cage, and I might kind of angle it back and look up towards where that RA is going to be, where the IVC jumps into the RA, and that's where I'm going to see that. Now, this patient here definitely has a flat IVC. See how as she's breathing in, boom, that IVC, almost the walls-like kind of touch here and there. It's small to begin with anyways. So this patient definitely needs some fluids. This patient, on the other hand, has a plump IVC. You could almost call it plethoric, is another term to describe that. In fact, here's the hepatic vein. The hepatic vein is even dilated out. This patient's so it's got so much fluid on board. Now, they may have congestive heart failure, or they may have another obstructive problem in the heart like pericardial tamponade or pulmonary embolism. So even though you see a big flat plethoric IVC, don't necessarily discount the fact that they might have either congestive heart failure, pulmonary embolism, or pericardial tamponade. So, but the good news with the rush protocol, you've already looked at the heart, right? Because that was all part of the pump. With EPSS, you already know what's going on and if they're at risk for congestive heart failure or not. So if you had a positive EPSS and then you saw all this going on here with this plump IVC and this giant hepatic vein, you'd be like, hey, this patient's got way too many fluids on board. We need to diurese. We need to give them Lasix and get some of those fluids, reduce their preload because they are in fluid overload. And the lungs can help you with that too in a separate way as well. Now, as opposed to this person here, has a flat IVC. In fact, this little lady, she's like in her 90s. I gave her a liter of fluid, and then she was still hypotensive. She had urosepsis. And the nurse was like, hey, Dr. Fox, you sure you want me to give another liter of fluid to this little lady? I said, well, hey, check it out. Her IVC is totally flat here. It's like we're under resuscitating her. We're not doing her any favors. We need to give her yet another liter. In fact, she required 3 liters of fluid before she's fully resuscitated. The worry is that an older person is more prone to go into congestive heart failure if you get too aggressive with the fluids. So that's why we do ultrasound on them, to monitor our fluid resuscitation using the IVC collapsibility. All right. Now, what about the eFAST? So talk about the tank. Okay. Pump tank pipes. We're in tank right now. We got through the IVC. Now we're talking about the FAST exam. The FAST exam is hepatorenal, cardiac, which we already did. So we're going to skip that. We're going to do hepatorenal, splenorenal, suprapubic. Okay. The eFAST, or extended component of the FAST exam, also includes looking at the lung for pleural sliding for pneumothorax, because a tension pneumothorax can also cause somebody to become hypotensive. So if you're bleeding into your hepatorenal area, bleeding into your splenorenal, or bleeding around your bladder, outside your bladder, we can see all these things on ultrasound really easily using the eFAST, and this can help guide our resuscitation and at least come up with an etiology of why they're having hypotension. And certainly if they have a tension pneumo, boom, you're putting either a large 14-gauge needle in their chest, or you're doing a chest tube, or likely both. Now, how do you do with eFAST? Pretty easy. Hepatorenal, you're going to be looking from the diaphragm all the way down through the lower pole of that kidney, looking for any free fluid between the liver and the kidney. You want to get all the way down to that lower pole. In fact, you do that on the left side as well. You want to see all the way around here for any free fluid. It looks a little something like this. When it's positive, here's your liver, here's your kidney, and boom, there's all that anechoic, sharp angle, that wedge of free fluid here. Very exciting whenever you have a positive FAST exam. It's nice to announce it loudly. This is the left side, spleen, kidney, no fluid between those two organs over here. We've got the probe on the left side of the body. It looks just like the right side of the body, except it's not called Morrison's pouch. It's called splenorenal view. And you can see here, here's that spleen. This is a coronal view with the indicator towards the patient's head. Come from the side of the body. This is towards the patient's feet, just like the right upper quadrant. Now we're in the left upper quadrant, and this one's positive for free fluid. And finally, we're looking in the abdomen around the pelvis as well. We do 2 views. We look in a sagittal view, fanning side to side. And you can use either the phased array transducer or the curvilinear transducer. We had a positive suprapubic window on my last shift that we picked up with the phased array, and everybody kind of saw it. And then I moved to use that big curvilinear, large footprint curvilinear probe, and it was like so beautiful to see that. I should put that clip in here. But this is another one here. This is a female who fell off the back of a motorcycle. This is the bladder seen over here. Here's that uterus, the anterior cul-de-sac, and then the posterior cul-de-sac is back here. We see some free fluid here behind the uterus, and therefore she had a positive FAST exam. Now, when we see a positive FAST exam in somebody, now this may be a ruptured ectopic, it may be a trauma patient, but I'll tell you right now, we activate the RIP protocol. We have this protocol where we get all these blood products together, packed red blood cells, platelets, tranexamic acid. Like we get rolling. This ramps up the resuscitation pretty aggressively. We notify the operating room this patient's probably coming to you, and then everyone starts mobilizing their forces, which is what's great about doing ultrasound, because you get a heads up early that somebody could crump on you. Now here's a transverse view. That was a sagittal view just on. Here's a transverse view. The bladder looks a lot more rectangular shaped. Here's an older gentleman with a pretty prominent looking prostate back here. The same place uterus is, the prostate sits behind that area back there. No free fluid on that exam. However, on this patient, fell off a ladder. He's on Coumadin. You could definitely see some free fluid here adjacent to his bladder in that little sharp angle. That's what we're looking for, sharp angles and wedges. This is normal to see fluid in the bladder, obviously, and this is adjacent to the bladder. Helps to have a full bladder to make that call. Now, the pneumothorax, and just to review it real quick, you're going to use a linear probe always. Sometimes you get away with using curvilinear, but I like linear better for pneumo. And patient breathes in and out. You can see that lung sliding back and forth in the absence of a pneumothorax, and that's good. However, when the lung slides away from the chest wall, you lose that visceral-parietal pleural interface, you lose the lung sliding, you lose that interaction, that artifact, and now it's the absence of lung sliding that is the pneumothorax. If the patient's breathing in and out, you're like, hey, where's that lung sliding? I don't see those ants marching around anymore. This patient's got pneumothorax. Now, sometimes they have a small pneumo or a large pneumo. You can actually trace it out using ultrasound, and you'll see the transition zone where, like, okay, at this rib level I'm seeing sliding. Oops, down here I don't see any sliding. I'll show you a couple examples of what that looks like. So again, the technique is a sagittal plane. The indicator is towards the patient's head. That's the most common question I get about doing a pneumothorax exam. Which way to aim the probe again, Dr. Fox? To the right, to the head? Yeah, towards the head, sagittal view. That's why we see like two ribs on the screen, right? Like rib number 2 and rib number 3, or maybe this is rib number 4 and this is rib number 5. Whatever. You can see the pleural line in between the two, and that's what we're getting at here. Nice lung sliding there, pleural line sliding back and forth, maybe a few comet tails as well. And when you've got a pneumothorax, what we're looking at here again, you see the two ribs, but now we're not seeing that sliding anymore. That pleural line, we see it there, but there's no lung sliding. And the reason why I like the sagittal view, and most others do as well, is because you have those artifacts of the ribs so that you can therefore define the thing between the two, which is the lung. Now I ask you, which patient has a pneumothorax, if either one? And your answer is, yeah, I totally see a pneumo on the left side. There's no lung sliding over here, and this patient's got this little sliding going back and forth. First few times you look for lung sliding, you're like, I'm not really sure I see it, what he's talking about there. But believe me, it becomes incredibly obvious to everybody in the room the first few times they start doing this, because you do see a lot of normals. You get used to seeing what lung sliding looks like. The majority of these patients don't have the pathology, but boom, when they do, you're like, whoa, there's no lung sliding here. That's a pneumothorax. And another example here, over here, we see the lung sliding back and forth. Okay, cool. So there's no pneumo there. What about on this side over here? Here's the rib shadow here. I'm not seeing a lot of lung sliding going on here. This looks like we're talking about pneumothorax over here. I'm not seeing lung. Tell the patient, come on, take a deep breath. And nothing. Okay. How about on this view here? We're seeing initially, look over here first. I'm like, oh, this is a pneumo. I don't see a lung sliding, but I do see a comet tail. And then boom, the patient takes a deep breath and you see it slide. And so maybe the patient was intubated and they bagged the person and they gave him a breath, mechanically or positive pressure wise. The same ultrasound pneumothorax looks the same whether you're doing positive pressure or spontaneous ventilations. But you could see here, once that breath was taken, now we saw the lung sliding. There's no pneumo here. In fact, I see a comet tail. Whenever you see a comet tail like that, that means that there is interaction of the visceral and parietal pleura to make that comet tail. And over here, looks like there's some pretty good lung sliding over here as well. Good. Okay, now the transition zone between a pneumo on this side and no pneumo over here is called the transition zone. This is sliding here, lack of sliding here. That's the actual point where the pneumo starts. So you can kind of mark it out. And as the patient's taking a deep breath over here, we see the lung sliding back and forth just fine. But over here, this is called the lung point or transition zone. Another example here, as this patient's breathing in and out, we can see that transition zone kind of wobbling back and forth there. Definitely pneumo going on over here. And this is the point at which the lung comes up against a chest wall. And another example of that over here, we see some comet tails, maybe some sliding. And then over here, there's definitely no comet tails and no sliding right here. This would be the transition zone or lung point. Okay, so where are we at with all this? We talked about the pump and the tank, and we just finished the IVC and the eFAST, including pneumothorax. Good. Now we're on to the pipes. Finally, we're almost done. The pipes, the aorta and the DVT. How do we do that again? All right, well, with the aorta, we're looking for a ruptured pipe, a ruptured AAA, abdominal aortic aneurysm. And we do that in the transverse plane. And then for DVT, we're looking in the femoral system, the popliteal system, for a clogged pipe. And we're going to use a linear probe for that, generally speaking. And for the AAA, we like to use that big curvilinear footprint transducer, though you could use a phased array transducer here, and you could use a curvilinear over here if you needed to in a larger patient. But ideally, these are the two probes I like to use for both these indications. Now, the aorta, goes along the left side of the vertebral bodies, as you see it coming down through the abdomen. Here's the chest. It comes out of the chest. And now we can see it when it becomes the abdominal aorta. And, there's that first branch, the celiac axis that goes to the spleen and to the liver. And then there's another branch over here, SMA. Not really important what those branches are right now. We're looking for a dilated tube. We're looking for this. We're looking for an aneurysm. And so you take that curvilinear probe and you just plop it down the aorta. You could do it in both the transverse and the sagittal plane. And you're going to see as the vertebral bodies get larger and larger and larger, the aorta kind of gets a little bit more anterior or superficial. And we can see it here. Here's the aorta stretching out across the screen here. We see the liver up here. This is the duodenum. Getting distracted by all these cool vessels. Here's the celiac and the SMA. But this is a normal looking aorta, just kind of pulsating along here in this normal person. Now, that was sagittal. Here's transverse. We can see the aorta here. Here's the IVC and a transverse view. Here's that Salvador Dali's mustache, or that upside down horseshoe that is the vertebral body that is our artifact of that spine shadow that we look for to define the aorta. So as long as your indicator is to the patient's right and you push hard enough, you're going to see the aorta. I have a lot of people tell me, though, I'm pushing real hard and I'm not seeing the aorta. What do I do? What is my answer? Use two hands and kind of warn the patient, explain what you need to do, and then apply a lot of firm, gentle pressure. And sometimes it's 30, 40, 50 pounds of pressure in order to get those loops of bowel to squirt out of the way so you can see that spine shadow, and then boom, there's your aorta right there. Okay? Moving along here, this was an interesting case. This was Dr. Megan Osborne, who saved the day on Catalina. She had a patient who came in there, and she took this video using her cell phone. I happened to be in Ireland, and she sent me the video and said, check out this AAA I found here. And so here you can see the hash marks, the centimeter hash marks coming down the side here. I mean, this is a good, probably, 7 or 8 centimeters here. You see blood kind of swirling around in there. And indeed, she got that patient off that island and into an operating room on the mainland side where the patient had a really good outcome. So guy came in, he had a syncopal episode, meaning he passed out, complaining of some back pain. She did a physical exam, did not feel any pulsatile masses. Usually you don't. But she got curious, and because ultrasound gives a clinician a very low threshold to pick up life-threatening conditions such as this, she discovered it. And she remains one of my favorite clinicians in the world. This here is another example of an abdominal aortic aneurysm. You can see the aorta is here. There's some mural thrombus over here blocking that pulsatility that you would expect to feel in the physical exam, which you don't, because of all this mural thrombus here, dampening the pulsatility of that AAA. All right, here's another AAA here. Big aneurysm all the way. I would measure from here all the way to here. Here's the lumen. This is all that mural thrombus here that's so common in these AAAs. And so, yeah, they get pretty big like this. They rupture, and the patient can have a really bad outcome. First, they leak, though. There's something called the sentinel bleed, and that's exactly what Dr. Osborne picked up. Guy came in. He had a sentinel bleed, meaning he leaked, and then it stopped leaking. So when it leaked, he passed out. He had a syncopal episode, but then he woke up, and he felt okay, but had some back pain. That story is the classic story for abdominal aortic aneurysm. Don't write it off as a back strain. Now, the last component of the RUSH protocol, and we're done with it, is called DVT, deep vein thrombosis. And what we're looking for here is a clog in either the femoral system or the popliteal system, or both. We're going to use that linear transducer, and we're going to go all the way down the femoral system into the popliteal looking for a blood clot. Because when you do find a blood clot, how does that cause hypotension or shock? Well, those blood clots can migrate right up the venous system, up the IVC, and into the right atrium of the heart, out to the lung, and become a pulmonary embolism and be fatal. And so sometimes this is your only tip-off. And the way you do it is you compress. You start up at that level of that inguinal ligament, and you make 1 centimeter compressions all the way down the leg as far as you can see. This area here is called the femoral canal. It's a little bit tough through here. It's hard to see, but it's important to get through there and then get to the pop. The reason I say it's important to get that femoral canal, which we see here, is this was a study looking at where do we miss clots. This was clots that were isolated. About 5% of clots are going to be isolated to this, at least in this study here, into this femoral vein area. So if you just do the femoral area, you skip this and go down the pop, you're going to miss about 1 in 20 DVTs that way. So make sure you march yourself all the way down, even though this is a difficult area to insonate. And this is what it looks like here. You just compress. Here's the right leg. Indicators to the patient's right. And the way I remember that is that venous rhymes with penis, or you could say venous vagina, and that's what's closer to the organ that's right here, not on the screen. So lateral is going to be these two arterial structures, and the vein is medial, venous penis. That's how I remember that. And I know that sounds kind of funny, but in the heat of the battle, you'll be upside down trying to do an ultrasound with your left hand, trying to put a central line in someday on some crazy crash code situation, and you'll forget about the other non-vulgar way to remember which is the artery and which is the vein, and you'll remember venous penis. And then you get down into the femoral area as we are here, and you'll see a clot. So here's the arterial system over here, and here's the clot in the femoral vein. We saw a little bit in the saphenous vein over here, and the saphenous vein here is confluent with the femoral vein. That's how far up in the inguinal area we are. So failure to wink back is the DVT. Now, when you find a DVT, you don't want to start milking it and make it into a PE best you can. You want to like record a video and then show it to everybody. Here's the popliteal artery. Here's the popliteal vein. The vein comes to the top and the pop. I think I might decrease my depth a little bit to make these structures a little bit larger, but otherwise this looks like a pretty good study. Now, when there's a clot there, you don't have compression. Here's the clot that's in the popliteal vein, popliteal artery here, and you don't have that winking back, and so you know you've got a clot there. So that's the rush protocol. There's a lot to it, and I know it's like I'm like Oprah Winfrey saying, you get an ultrasound and you get an ultrasound and you get an ultrasound, but it's you can probably, when you get good at it, you could probably bust through a whole rush protocol in probably less than 5 or 6 minutes if you move the probe swiftly. And so the hardest one of all these is that apical 4-chamber view, because to get the right view, it requires you to reposition the patient. So if you're really thinking PE and you're having a tough time with that view, you could come down here right away, maybe look for a DVT if you can't get that patient rolling their side. But that's the idea: the pump, the tank, and the pipes. And yeah, you're switching probes a lot, which is why it's nice to have a triple transducer connector, have a way to quickly switch between the probes without having to disconnect them and reconnect them. So in most clinical areas, certainly in our resuscitation bays, we have those. All the probes are always connected and always fired up, ready to go at any time. And that really, makes doing a rush protocol like that in resuscitation bay much, much faster. So, all right, well, thank you very much.